Thank you for joining us for today's webinar. The Bassler Center for BRCA at Penn Medicine's Abramson Cancer Center is the first and only comprehensive center solely devoted to funding research across the globe, educating providers and patients, and advancing care for individuals with a BRCA1 or BRCA2 gene mutation. Dr. Edward and Merry Prostic have generously established this webinar as part of the Elizabeth Prostic Memorial Outreach Program in memory of their daughter. The following video is a tribute to Elizabeth, her incredible life, and her dream of creating communities that increase awareness about BRCA and metastatic cancers. The Bassler Center is proud to be a part of this mission by providing life-saving information and hope to individuals and families worldwide. And please begin the video.
Tomorrow, bet your bottom dollar that tomorrow there'll be sun.
Lizzie Prostic was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls, and with boys. Sophomore year of college, Lizzie met Michael Lundblad. A liberal and an English major, he got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sonnenschein, Nath, and Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it, but she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
The webinar was also generously co-sponsored by the VML Foundation, the employee-led official nonprofit arm of VML. Their extensive community outreach program supports a wide range of projects and includes raising funds in support of and volunteering at animal shelters, hospitals, food banks, community centers, and more. Today's program will discuss issues with fertility and reproductive decision-making for BRCA carriers and their families. As always, this presentation will be archived and available for viewing later this week. I'd like to introduce our speaker, Dr. Clarisa Gracia, MD, MSCE, an Associate Professor and Board-Certified Reproductive Endocrinologist in the Division of Reproductive Endocrinology and Infertility within the Department of Obstetrics and Gynecology at the University of Pennsylvania. She has practiced as a reproductive endocrinologist at Penn Fertility Care since 2004 and has appointments at the University of Pennsylvania Hospital and the Children's Hospital of Pennsylvania. She has an active clinical practice in the area of reproductive endocrinology and infertility, including IVF and reproductive surgery. Given her particular interest in the reproductive effects of cancer therapies and fertility preservation, Dr. Gracia established the Fertility Preservation Program at Penn and is also Director of Clinical Operations and Third-Party Reproduction. And Dr. Gracia, the floor is yours.
Thank you so much for the kind introduction. It's a pleasure to be here giving this webinar today. The objective of the webinar is really threefold. One, to discuss the unique reproductive concerns in patients at risk for breast and ovarian cancer, so I'll spend some time discussing those. I'd also like to describe some of the available methods for fertility preservation that are currently used, and then discuss kind of the process and arguments for and against the use of pre-implantation genetic diagnoses, particularly in patients with BRCA mutation. So just to give a little background, BRCA mutations are a major cause of breast and ovarian cancer in reproductive age women, and it's been estimated that approximately 1 in 200 to 1 in 800 individuals carry a mutation overall. It's much more common in the Ashkenazi Jewish population with a carrier frequency of around 1 in 40. Women with BRCA1 mutations have a 65% lifetime risk of breast cancer and about a 39% lifetime risk of ovarian cancer. So the risk is significant. And currently, it's recommended that women with BRCA mutations undergo risk-reducing prophylactic oophorectomy because it's really been shown to be effective in decreasing the risk of cancer. The timing of this procedure is still a bit controversial, but depending on family history and so forth, it could be recommended as early as 35 years of age. And I think with respect to reproduction, that's important because many couples and women have not completed having children by the time they're 35 or even 40. So women with BRCA mutations, I think, really do have unique reproductive concerns. As I mentioned, risk-reducing strategies, including removal of the ovaries and tubes, can significantly shorten a woman's reproductive window, given the fact that couples and women often have not completed childbearing by 35 or 40. In addition, these women we know are at high risk for breast and ovarian cancer, and if they are diagnosed with these during the reproductive years, they face having treatments including things like chemotherapy, which can significantly impair fertility as well, and we'll talk a little bit about that. And then finally, women who do conceive with these mutations are at risk of passing the mutations on to their offspring. And as a result, women with BRCA mutations often see fertility specialists because they seek guidance about how to best kind of coordinate their reproductive efforts. More and more women with BRCA mutations are actually choosing to have fertility preservation procedures, mainly IVF, so they can freeze eggs or embryos for the future, particularly those who develop cancer before they've completed childbearing. In addition, some women are also choosing to have IVF with pre-implantation genetic diagnoses to avoid passing on the mutation to their offspring. In addition, I think it's important to recognize that there is some preliminary evidence suggesting that BRCA carriers may also have altered ovarian function, which may be a result of kind of physiologic changes that occur in these mutation carriers. One small study showed that women with BRCA mutations responded less well to stimulation for IVF, suggesting they have fewer eggs in their ovaries. And also one study found that these women may actually go through menopause sooner than women without the BRCA mutations. And while this is controversial, I think it is also a consideration in these patients in terms of thinking about the future reproduction. So our research group has also conducted a study to really determine whether having a BRCA mutation really impacts a woman's reproductive decision-making. We surveyed over 1,000 BRCA carriers through FORCE, and we had some interesting results. Among women who were unpartnered at the time they answered the questionnaire, about a quarter reported that they felt more pressure to get married compared to not having the BRCA mutation, and about a third said that having the mutation really influenced the characteristics they were actually looking for in a partner, which is interesting. Those women with BRCA mutations who had not yet completed having kids, about a third of them reported that their mutation impacted their decision to have biological children overall, whether they wanted them or not, for example. A third of them felt that they were more likely to consider fertility treatments to get pregnant more quickly, given the fact that they were facing oophorectomy. A fair number also were more likely to consider in vitro fertilization to freeze eggs or embryos for the future, and about a third were actually likely to consider IVF in order to do pre-implantation genetic diagnoses. So it does appear that having a BRCA mutation really does impact a woman's decision about reproduction. It's also important to be aware of the American Society of Clinical Oncologists guidelines regarding fertility preservation. This document really particularly focuses on the reproductive risks of cancer therapies and methods for fertility preservation, but I think the guidelines also apply to patients with BRCA mutations as well, given the risks associated with these mutations and the possibility of actually being diagnosed with breast or ovarian cancer at a young age. Essentially, this document really encourages clinicians to discuss the fertility risks related to various conditions and their treatments as early in the treatment phase as possible, so as to kind of maximize options, especially with respect to fertility preservation. So given the higher risk of breast cancer in this population, I also wanted to review some of the reproductive risks of breast cancer treatments. The biggest risk to fertility is chemotherapy. Breast cancers are usually treated with multi-agent chemotherapy regimens like adriamycin, Cytoxan, ACT. These are some of the regimens that are given to breast cancer patients, and often they contain a drug called cyclophosphamide, which is known to destroy eggs within the ovaries and can lead to early menopause or potentially to infertility. Second, often estrogen-sensitive tumors are treated with adjuvant hormonal therapy, either tamoxifen or ovarian suppression, for 5 years. And while these treatments don't destroy eggs in the ovaries themselves, it's really not possible to get pregnant or it's not recommended that women get pregnant while they're using these medications. So essentially, these treatments require that women postpone having children. So how damaging is chemotherapy? Most studies have actually looked at the likelihood of permanent menopause after chemotherapy to kind of get an idea of how much damage has been done to the ovaries. So most women who get chemotherapy will actually stop getting their periods for about 6 to 12 months immediately during and after chemotherapy. And then those women who still have eggs remaining in the ovaries will typically get their periods back. It turns out that the younger you are, the more eggs you have in the ovaries, the more likely you are to get your periods back after chemotherapy. And this slide here shows that almost 90% of women less than 35 years of age at the time of chemotherapy regained their monthly periods after 6 months, whereas only about 20% of women who were at least 40 years of age began menstruating again. So there's no question that the age effect is really important. It is also possible to assess a woman's fertility by assessing hormone measures and also doing vaginal ultrasounds. So the most common hormones that we assess when trying to get a sense of a woman's, the number of women's eggs in a woman's ovaries is a hormone called follicle-stimulating hormone. That is a hormone produced by the pituitary gland that essentially tells the ovaries to kind of produce eggs every month. As the number of eggs go down in the ovaries, the brain produces more FSH in an effort to get the ovaries to produce eggs. So a high level of FSH actually means that there are fewer eggs. Anti-Müllerian hormone is another hormone that's actually secreted by cells around the follicles in the ovaries. And as the number of eggs or follicles goes down in the ovaries, the amount of anti-Müllerian hormone goes down. So a low level is bad. And finally, we can do vaginal ultrasounds where we can literally see tiny fluid-filled sacs in the ovaries, these little black dots, and count them up. And essentially, we're looking for a high number. Over 10 is considered normal. So we have studied these measures of ovarian reserve in cancer survivors and compared them to women of similar age without cancer. We have found that these measures of ovarian reserve, again, follicle-stimulating hormone, anti-Müllerian hormone, and antral follicle counts, look worse in women who've received chemotherapy, suggesting that indeed the chemotherapy destroys eggs in the ovaries and that women after treatment are left with fewer eggs in the ovaries than before treatment. I mentioned previously that there are also some studies suggesting that women with BRCA mutations have fewer eggs in their ovaries even without any exposure to chemotherapy. We also conducted a study through FORCE looking at AMH levels in women with BRCA mutations without a history of cancer or cancer treatment. And we found that women with BRCA2 mutations had lower levels of AMH compared to women either without mutations or with BRCA1 mutations, suggesting again that women with BRCA2 mutations may actually have fewer eggs in their ovaries in general than other women. So I mentioned this, that while it's still controversial and there's still conflicting information on this topic, I did want to mention it because it may be a particularly good idea for women with BRCA2 mutations to preserve fertility before cancer therapies, given the fact that they may be starting out with fewer than other women. It's also important to be aware that age is the biggest factor related to fertility in general. This slide shows the rates of pregnancy in populations of women as they age. A woman is most fertile before the age of 30, and fertility really starts to decline after about 35 and even more after 40. After 45, it's extremely rare to become pregnant. And so again, it's important to keep in mind a woman's age apart from the BRCA mutation and other risks associated with the BRCA mutation. A woman's age at the time of getting pregnant is really the most important predictor of having a baby in the future. The reason that fertility declines as a woman ages is kind of explained by this slide here, showing that eggs become chromosomally abnormal as a woman gets older. This graph basically shows the percent of embryos that are found to have abnormal number of chromosomes by a woman's age. And you can see that around 30% of embryos are abnormal between the ages of 26 and 32 years of age, and that rate rises sharply so that about 85% of embryos are abnormal in women 43 years of age. Most of these embryos do not result in pregnancy or end in miscarriage, which really explains the age-related risk of infertility, which I showed on the previous slide. So now I want to transition a little bit and talk about options for fertility preservation. One option that shows some benefit for protecting the ovaries in women undergoing chemotherapy for breast cancer is the use of ovarian suppression during chemotherapy. A medication called goserelin or Lupron can be given during chemotherapy to put women in a temporary state of menopause. And there are now a couple of studies that suggest that women who get this treatment have a better chance of getting their periods back and possibly a better chance of getting pregnant after treatment. While the benefit is thought to be likely relatively small, this treatment is something that may be recommended to help reduce the reproductive risk of chemotherapy in women with breast cancer, so I did want to mention it. Most of what we offer in terms of fertility preservation really involves assisted reproduction. This slide presents an overview of assisted reproductive techniques available for fertility preservation in females. Essentially, women can undergo the process of ovarian stimulation, which I'll describe, and essentially have a minor procedure to remove eggs from the ovaries. Either eggs can be frozen at the mature state, or if a woman has a partner, eggs can be combined with sperm, and embryos can be frozen. These are both considered kind of established fertility preservation methods. Methods that are not quite established that I'll review as well today include something called in vitro maturation, where immature eggs are retrieved from the ovaries and then matured in the laboratory to either freeze mature eggs or to fertilize the eggs and freeze embryos. And alternatively, it may be possible to remove a piece of ovarian tissue surgically, which contains potentially thousands of eggs, and that tissue can be frozen for later use. So embryo cryopreservation has been around and available for many years. It's principally an option that's only really available to couples, so women who have a committed partner, because in order to use those embryos, you need consent from the partner. So typically these are married individuals who are pursuing this technique. Success rates are quite good, and here are data from the Society of Artificial Reproductive Techniques, which tracks IVF data throughout the United States. So in women less than 35 who use frozen embryos, the likelihood of having a baby per embryo transfer is about 43%. It does go down as women get older, but this technique does work quite well. The more embryos a woman has frozen, the more chances she will have to have a baby from those embryos. By far the biggest achievement in reproductive medicine in the past 5 years has been our ability to freeze and thaw eggs. This has not only allowed us to provide females the option of preserving fertility without having a male partner, and now it's no longer considered experimental as of 2012, according to the American Society of Reproductive Medicine. In particular, the American Society of Reproductive Medicine stated in the original document that this is a particularly good option for patients facing infertility due to chemotherapy, for example. but obviously patients should be counseled appropriately. So the reason egg freezing has improved so dramatically over the past 10 years has really been because there have been significant changes in the technology related to freezing. Now we use something called vitrification, which is a very rapid freezing method where the eggs are dehydrated and then plunged into liquid nitrogen, whereas before we were principally using a slow freeze technique that unfortunately was not as successful. There have been a variety of randomized trials in patients who are young, principally egg donors and young infertile couples, showing that egg freezing does work, and the success is similar to actually using fresh eggs for IVF. So overall, over 90% of the eggs survive the freezing thawing process. Over 70% of frozen eggs will fertilize. Overall, the likelihood of pregnancy from frozen eggs ranges from about 4 to 12% per cycle, generally about 6% chance of pregnancy per egg thawed. That number sounds very low, I realize, but when you think about egg freezing, we tend to freeze multiple eggs at one time. So if you freeze 10 eggs, there's about a 60% of chance of having a baby from those eggs. So there's also been accumulating information about the success since egg freezing has become more popular, particularly for aging women. One study of over 1,400 women who froze their eggs at around 37 years of age found that the cumulative live birth rate per patient was about 50% in women who froze their eggs when they were less than 36, and about 23% in women who froze their eggs over the age of 35. The more eggs you freeze, the higher the cumulative likelihood of having a baby from those eggs, so the more times you can try to have a child. So these graphs here kind of show that in women less than 35, the more eggs you have, the higher the likelihood of pregnancy, and it's quite a bit higher in young patients compared to older patients. So again, if you're going to freeze eggs, it's better to do it at a younger age, ideally when a woman is less than 35, because it tends to work better. There's also some information about the success of egg freezing in cancer patients who freeze before chemotherapy and then come back to use those eggs to achieve pregnancy. And while there's less information out there, the success rates seem quite similar to women who are freezing eggs for other indications, which is reassuring. So what is the process? Well, in order to freeze eggs or embryos, essentially it involves a 2-week process of administering injections of follicle-stimulating hormone under the skin. They're very tiny needles that get attached to a kind of a pen, kind of like insulin for diabetics. Essentially, women inject themselves every day for anywhere between 8 to 14 days. This stimulates the growth of multiple follicles or eggs in the ovaries, and women come in for close monitoring. Essentially, they come in the mornings for ultrasounds and blood work to assess how many eggs are growing in the ovaries. The goal is to grow anywhere between 5 and 30 eggs in the ovaries at one time to get a good number of eggs or embryos to work with in the future. And then women undergo a minor surgical procedure where they're put to sleep under anesthesia. An ultrasound is placed in the vagina with a needle attached, and the needle goes into the ovary, and follicles, the fluid-filled sacs that contain the eggs, are aspirated from each ovary. The procedure takes about 20 minutes, and typically women go home the same day with very little pain or issues post-operatively, so it's a safe procedure. One of the concerns in the setting of breast cancer is the fact that when we stimulate the ovaries with these medications and produce multiple eggs, estrogen levels do go up above the normal levels during a normal cycle. For many years now, since I would say 2006 when this original publication came out, we have used letrozole as an adjunct to stimulation in order to keep estrogen levels in a more normal or physiologic range, with the idea that there would be less potential for stimulating the growth of breast cancer if it existed still in the breast. And so this medication essentially is a pill that you take in combination with the injections, and levels of estrogen stay quite low. Even with that medication, results seem pretty similar. We get a similar numbers of eggs, similar numbers of embryos to work with. And so we've been very successful in using this protocol. In terms of the safety of stimulation, there have been some studies assessing the likelihood of survival and relapse among women who have received stimulation compared to women who have not received any stimulation to freeze their eggs in the setting of breast cancer. And the results seem quite reassuring in that the relapse-free survival is similar whether a woman received stimulation or not. We also worry about the safety of pregnancy, particularly for women with a history of breast cancer. But there have been a number of observational studies looking at the survival in women who conceive and who achieve pregnancy in the setting of breast cancer, and it does not appear that the risk of death is any higher amongst women who have a pregnancy after breast cancer compared to those who don't. So most oncologists will allow women to conceive and deliver a baby after a diagnosis of breast cancer if they're doing well. But we obviously encourage patients to talk to their oncologist and discuss the particular situations whenever thinking about pregnancy. So what are the benefits of freezing eggs or embryos? These are both established techniques, as we discussed. One of the benefits is that if a patient does not wish to become pregnant herself because she wants to continue ovarian suppression or tamoxifen, for example, in the setting of breast cancer, she could use these eggs or embryos in order to have another woman carry the pregnancy. So a gestational carrier could carry a pregnancy. It's rare, but sometimes cancer treatments cause health problems later on, and occasionally it's not safe for a woman to achieve pregnancy herself, and that would be a reason why she might elect to use a gestational carrier. The other benefit of freezing eggs or embryos is the fact that you can perform pre-implantation genetic diagnoses and actually test the embryos to see if they carry a BRCA mutation to avoid passing it on to a child. Just to mention that there are some investigational options for fertility preservation as well. I mentioned in vitro maturation, which is really trying to retrieve eggs from ovaries with very limited or no stimulation at all. The benefit is that you avoid the high estrogen levels, but the reality is these techniques have not been very successful, and so we prefer traditional ovarian stimulation with egg or embryo freezing. The other technique that has received a lot of attention and is performed a lot in Europe is ovarian tissue banking. The benefit of this technique is that you don't have to stimulate the ovaries at all in order to get the eggs. You simply undergo a surgery like a laparoscopy, go into the abdomen, with a telescope, take a piece of an ovary or an entire ovary, which contains potentially thousands of eggs, and then freeze the tissue. The problem is that in order to utilize the tissue has to be transplanted back into a woman's body later on. And in BRCA mutation carriers, this would not be recommended, since it's recommended to remove the ovaries given the risk of ovarian cancer. In the future, it may be possible that we may be able to use this tissue, identify the eggs, and grow the eggs out to use those for IVF, but this technique is pretty complicated, and there are still a lot of studies being conducted in animal models as well as in humans to figure out if this is even will be a possibility in the future. But for now, ovarian tissue cryopreservation is really not the best option for BRCA mutation carriers. So what about pre-implantation genetic testing? This is a very important option that I think should be discussed with all patients with BRCA mutations, because essentially it allows us to biopsy the embryos and transfer unaffected embryos in order to avoid passing on a mutation to an offspring. We see lots of couples who come to pursue IVF for this reason, either because they know they carry the mutation or because they've had a baby who has a disease. They didn't realize they were carriers until they had that child, and then they want to avoid having a child in the future with that particular disease and avoid having to do prenatal testing in pregnancy and consider terminating a pregnancy, which is much more difficult. The other thing is that you can biopsy the embryos and also screen for the total number of chromosomes. As I mentioned before, the number of abnormal chromosomes, the embryos become chromosomally abnormal as a woman ages, so this can be an option in order to try to maximize the likelihood of having a healthy baby as a woman ages. So PGD is somewhat controversial for BRCA mutations, principally because it's an adult onset disease, and there are things you can do to help prevent the development of breast and ovarian cancer. However, studies have shown that the majority of BRCA mutation carriers think that PGD should be offered to all BRCA patients, but actually only about a third say that they would pursue PGD themselves. A third of women state that they would actually have prenatal diagnosis, which means they have like an amniocentesis or testing during pregnancy. And even fewer say that they would actually terminate a pregnancy for a BRCA mutation. The bottom line is, I think most women do want information about the PGD process in order to make an informed decision about, about whether they would want to do this or not. So in terms of what's required in order to move forward with PGD, essentially the first step is to determine the actual mutation that a patient has, and then develop a probe in order to test for that mutation at the level of the embryo. Sometimes that takes up to 3 months, depending on the actual mutation. If it's an unusual mutation, probes have to be developed. If it's a standard, very typical mutation, that can be much quicker because there may already be probes available. We also need to have a routine evaluation for a couple, which includes testing how many eggs a woman has in her ovaries, as I mentioned before, checking a sperm count for the male partner, and making sure the uterus looks okay to transfer an embryo. We pretty much schedule patients for the IVF process after we know the mutation and we know that PGD is an option. The stimulation is similar to what I described already, about 2 weeks of injections to grow the eggs in the ovaries, and then have an egg retrieval and remove the eggs. We fertilize those eggs to create embryos. We culture the embryos typically over 3 to 5 days. We biopsy the embryos, and then we typically we'll transfer the embryo at a later time. So unfortunately, my videos are not working, but this was supposed to show you a slide of how we fertilize eggs. When we do PGD, we recommend intracytoplasmic sperm injection, where we physically take a sperm and inject it into an egg. This avoids contamination, kind of genetic contamination of multiple sperm around the egg. So it's recommended when we do PGD. This slide kind of demonstrates the development of embryos. Initially, we obtain an egg, we fertilize the egg. This is a fertilized egg. The day after the egg retrieval, it has a male and a female pronucleus. The embryo begins to divide into 2 cells, 4 cells. On day 3, it typically is an 8-cell embryo. By day 5 or 6 of growth and culture, it becomes a blastocyst. A blastocyst has essentially 2 layers, an outer layer of cells, which is called the trophectoderm, which becomes the placenta, and an inner layer of cells called the inner cell mass, which becomes the actual baby eventually, and it's surrounded by a shell called the zona pellucida. I have a video, which again is not working, but in order to do PGD, I'll show you a picture. For a day 3 embryo, you make a hole in the zona pellucida and then typically remove a single cell at the day 3 stage. For a day 5 embryo, you make a little hole in the zona pellucida and essentially remove several cells, 5 to 6 cells from the placental layer, trophectoderm layer of the embryo in order to send the cells for analysis. Typically, we can do day 3 or day 5 biopsies, but generally nowadays almost everybody biopsies on day 5 because we can get more cells for biopsy, so it's a little bit more accurate. And we're biopsying, when we wait till day 5, we're biopsying what we know will become the placenta, so there's an idea that we may be doing less damage to the embryo itself. Typically, we do not get results the same day. We send the biopsies out, we freeze all the embryos, and then essentially once the results come back, we determine which embryos we want to transfer, and then we do a frozen embryo transfer cycle where we prepare the uterus for implantation and then transfer the embryo into the uterus. This slide gives you a little bit of information that's been published on kind of the information about PGD, the likelihood of success overall when we're looking at single gene disorders like BRCA mutations. So European data, 57 centers and over 9,000 PGD cases in women who are in their mid-30s showed that about 5% of the cycles were canceled. Overall, the pregnancy rates were 27 to 30% per transfer, about 10 to 13% miscarriage rate, and misdiagnosis was very rare. Less than 5% of cases there was misdiagnosis. Specifically for BRCA mutations, there's a little bit less information available. This study was published in 2014 from 2 European centers looking at 70 couples with BRCA 1 and 2 mutations who underwent PGD. They went through about 2 cycles each, so 142 IVF cycles in 70 couples. These were day 3 biopsies. The embryos were grown and frozen before the results were obtained. And the pregnancy rate per retrieval was about 28%. Per embryo transfer was higher, so if those couples who had normal embryos to transfer into the uterus, about 40% of them got pregnant per embryo transfer. What's important to recognize is that couples may need to go through multiple cycles of IVF in order to obtain unaffected embryos, especially if you also want to test not only for the BRCA mutation, but also for the number of chromosomes overall. Obviously, an older woman will have fewer normal chromosomes, and overall, 50% of all the embryos will be affected by the BRCA mutation. So if you have 10 embryos, blastocysts that are biopsied, half of them will be BRCA positive, and then potentially another half will be chromosomally abnormal. So again, the numbers do go down, so often you have to go through more than one cycle. Cancellation happens less than 10% of the time. We think that biopsy is generally safe, but there may be some damage that happens to the embryo just from doing the biopsy itself. Sometimes we get embryos that don't give us a diagnosis because somehow there was a problem in amplification or at the analysis level. It is possible to have a misdiagnosis, although it's rare. And another important thing to consider is how many embryos to transfer. Typically, when we are screening for the total numbers of chromosomes, regardless of a woman's age, if you have a chromosomally normal embryo, we recommend transferring one embryo at a time. It's also important to consider what you would want to do with the embryos that you have that are left over, especially after you're done having children. Some couples may have a lot of leftover embryos that could be donated to another couple or to research or potentially discarded later on. Generally, PGD is thought to be safe. The risk of birth defects is similar to the overall population. The biggest risk is the risk of multiple pregnancy because more than one embryo often is put into the uterus. Hopefully, with our new guidelines of transferring one, this risk will be lower for sure. Other risks are that women can develop hyperstimulation syndrome, which is a syndrome where you can develop an excess of fluid in your abdomen, enlarged ovaries. This is pretty rare nowadays. It's very rare to twist an ovary and to have infections or bleeding. At Penn, we've now done many cycles of PGD and PGS for multiple indications. We have had patients who've pursued PGD for BRCA mutations. Just a couple examples include 30-year-old patient with a BRCA2 mutation. She went through ovarian stimulation. We got 21 eggs. 18 eggs were mature for the intracytoplasmic sperm injection. 15 of her eggs fertilized. She had 7 blastocysts that were biopsied. 3 had a BRCA, were not affected by BRCA. Oh, sorry, 3 were BRCA positive. 1 was BRCA negative and chromosomally normal. So she ended up transferring that one embryo and delivered a healthy baby. The second patient was 27 years old, had a BRCA mutation, 24 eggs were obtained, 18 were mature for intracytoplasmic sperm injection, 13 of them fertilized. She had 10 blastocysts, 5 were BRCA negative, but only 2 of those were chromosomally normal. And so she ended up transferring 1 and delivered a baby and has 1 embryo left over, potentially for a second child. So that gives you some idea of how this works in practice in terms of the numbers. What are the costs? Unfortunately, many insurances do not cover these services. It really depends on the insurance company and employer in the state of Pennsylvania. Egg and embryo freezing can cost anywhere between $7,000 and $15,000, as does IVF. Sometimes there's added costs associated with the fertilization process with ICSI. Pre-implantation genetic diagnosis can cost an additional $3,000 to $7,000 on top of the IVF cost. Other options for having children include using an egg that's been donated from another woman, having someone carry a pregnancy for you, or adopting. These are not inexpensive options either, unfortunately. There are some resources available through infertility organizations like Resolve that can help defray some of the costs. And we do provide discounts for patients with cancer who are undergoing fertility preservation. Ultimately, the decision to go through any of these procedures really depends on kind of thinking about how much is it going to cost you, what are the risks related to the procedures, and how likely is it that you will have a successful outcome from these techniques. And so it's really a discussion that should be had with the physician, sorting out whether this is something that a patient with a BRCA mutation would want to pursue. I think it's important to recognize that making decisions about fertility can be incredibly stressful for patients. It's a really emotionally charged issue. Fertility treatments often sound scary and invasive, and having educational material can be very helpful. We also have a counselor in our office who talks to all our cancer patients, as well as patients who are struggling with fertility issues, as well as other concerns. It is important to know that there are other options for having children. I mentioned egg donation. This is where another woman donates eggs to a couple trying to get pregnant. Typically, these women are young, less than 35 years of age, so the success is very good, typically over 60% likelihood of having a baby per cycle. The good thing about it is that the person carrying the pregnancy still plays a major role in the pregnancy, can still breastfeed, and their partner can still be the biological parent, even though they are not technically a biological parent. It also can be attractive to BRCA patients because it avoids passing on the BRCA mutation to a child, but it can be expensive, and so this is one option. It is sometimes possible to get embryos that have been donated from another couple. Often the success really depends on the scenario. How old was the female who's donating the embryo? It tends to be less expensive, but often there are waiting lists of couples who are waiting for an embryo to become available. And then finally, adoption can be a great option for a lot of couples as well. So overall, I would say there have been, great strides have been made in reproduction in general to really expand the reproductive options of all patients, including those with BRCA mutations. I think it's really important that patients be educated about all of the options that are available, including fertility preservation, including IVF with pre-implantation genetic diagnoses, and everything that we talked about today to really make an informed choice about how to have a family. There's no question that more research is needed to determine how best to apply reproductive technologies in the BRCA population, and how to kind of mitigate the reproductive risks associated with the diagnosis. It would be great if we could find a better way to reduce the risk of ovarian and breast cancer without having to remove the ovaries and tubes at a young age. So I appreciate your attention, and I'd like to thank the Vassar Foundation, my collaborators at the Abramson Cancer Center and at Children's Hospital, as well as the Oncofertility Consortium, and FORCE for supporting some of the research that we've done in this area. And thank you very much. I'm not sure we have much time for questions or if there are any, but I will I'll take anything at this point.
I think we are actually out of time, and it doesn't seem like we have too many questions, but people can still email in, and I will forward them on to you. Thank you so much to Dr. Gracia, and today's presentation will be archived and available for viewing later this week, along with the past Vassar Center webinars at vassar.org/webinar. And thank you again to Dr. Edward and Merry Prostic and the VML Foundation for making this event possible, and enjoy the rest of your day.